El profesor Johannes Giesinger, primero, es uno de los expertos en evaluación en calidad de vida a nivel internacional, es miembro del grupo de calidad de vida de la EORTC y es uno de los que más papel hace en la metodología de evaluación de calidad de vida en la práctica clínica y en general. Yo creo que I'm saying we are very good friends, that you are a member of the EORTC Quality of Life group and you are one of the leaders of the methodology development in the group. Es de Innsbruck, de la Universidad de Innsbruck, y aunque anda entre Innsbruck e Italia, en Roma, en el Instituto IMEMA de Hematología. Y es una persona muy accesible en el sentido de que luego cualquier que le queráis preguntar ahora o después, sin ningún problema. I'm saying that they're a very nice person, very easygoing. We are very good friends, and anyone who wishes to talk to you, we can talk now or later. Yeah. And the idea is that la idea es que las diapositivas están en castellano, sí, lo hablo en inglés, pero están todas en castellano. Lo que decíamos, las preguntas se pueden hacer tanto en la sala, tenemos micrófono, como desde casa, donde sabemos que hay bastante gente conectada.
Thanks a lot for a very kind introduction and for having me here to present on the assessment of quality of life in clinical practice. So as Juan already mentioned, I'm just trying to click here. As it's kind of a disclosure, it's not financial, but still a disclosure. I'm like a member of the European Organization for Research and Treatment of Cancer, Quality of Life Group, the EORTC. Like much of my research and my activities are within this field of cancer research, and it explains the focus of my presentation. So in my talk today, I want to give like a quick introduction to the topic, like some basic terms and definitions, some background, basically. Then I want to focus on the implementation of routine assessment of patient-reported outcomes of quality of life, basically in the context of oncological practice. I want to focus on the interpretation of PRO data, patient-reported outcome data, which is often considered a challenge. And finally, I want to focus on the benefits, why you should do this, what are like the advantages of having this kind of data collected in daily practice. And I'm going to finish with an outlook on existing guidelines that might be helpful and some key points. So I want to start with like two very basic concepts. Like the one is like, as most of you will know, like the concept of patient-reported outcome. And there are different definitions of this. I want to show here the one from the European Medicines Agency. And it very simply states the patient-reported outcome is basically any report on an outcome of a medical situation that is reported directly by the patient. So the important thing is it's not from a clinician, it's not a clinician rating, it's not a lab test, it's a patient report in the end. And it's a very broad umbrella term that can relate to like symptoms, health rate, quality of life, I'll get back to that, health status overall, but also things like adherence to treatment or satisfaction, etc. And closely linked, and historically, I would say a little bit older, is the term of health rate, quality of life, which is like a multidimensional concept. It's very similar to the, I would say, to the WHO definition of health in general from 1948. And it focuses on the different domains of like physical health, psychological well-being, and social well-being, with a focus on also on the daily impact a disease or its treatment can have on daily life. So sometimes these terms are used a little bit interchangeably, but patient-reported outcome puts the focus on the data source, the patient report, whereas health-related quality of life puts the focus on what is being measured, this multidimensional perspective on health. So in the field of cancer, to give like an idea what it means like more specifically, there are like, for example, these core symptoms that are considered to be important across different types of diagnoses. Key symptoms in cancer, like for example, fatigue, pain, gastrointestinal symptoms, sensory neuropathy, appetite loss, etc. And this is usually accompanied to have like a better picture, a more comprehensive picture with functional domains, functional health domains. And from the perspective of the EORTC, there are like basically 5 of them: physical function, role functioning, social functioning, emotional and cognitive. And what you can see here is like emotional and cognitive is kind of similar to the symptoms. So it's not always completely clear what is like a symptom, what is like a functional health domains. But this is like content-wise, the things that we mostly measure when we measure health-related quality of life or PROs in the field of cancer research. So what does this look like specifically? Like this is like the EORTC QC30, the quality of life questionnaire core 30. That's the most widely used questionnaire for the assessment of PROs in cancer research. It looks like this in Spanish. There's like 30 items, 30 questions, and they measure 15 different symptoms, and functional health domains. And so the items in this questionnaire, like the questions, are like kind of combined to so-called scales. And the first items, for example, form the physical function scale. So like content-wise, they're all about physical function of the patient, but they're also like questions on role functioning and, for example, on dyspnea. And the way these questionnaires work is like these questions are combined, and from the individual responses of a patient, a score is calculated. And for this questionnaire, this score has a range from 0 points to 100 points. And if a patient, for example, responds like this, it might be 67 points for physical function, 83 points for role functioning, and 33 points for dyspnea. And as you can tell, maybe it's like a little bit difficult to interpret these scores. What do these numbers really mean? But I'll get back to that in one of my parts of the talk. But as an outlook. So why would you collect these data in daily practice? What's like the intention behind this? In clinical trials, it's very obviously about assessing clinical benefit, treatment tolerability, and it's a bit similar in the context of daily practice. You might want to use these questionnaires to screen for symptoms. For example, you might want to screen for psycho-oncological treatment needs, for sexual dysfunction during treatment, etc. So it's like screening for symptoms and impairments to have like better treatment of this. Might also be like monitoring, more like over time, to assess the impact of your treatment, of your intervention. For example, you might want to use these questionnaires to monitor chemotherapy toxicity over the course of chemotherapy. Or you might want to assess the impact of a pain intervention that you're giving to reduce the pain of the patient. Another use of these questionnaires to assess it over time. Beyond that, it allows you to collect like standardized data over a longer period of time, basically across the disease and its treatment, to have like a historical data, have like a systematic approach to measuring the trajectory of symptoms and health over time. And this can be like very important also in the context of changes in your treatment team, of changes of the treating physician, clinician. So it provides like more continuity of care because like all the health professionals involved in treating a patient might have access to this data, have like understanding what has happened before they see the patient. Another use is like obviously like by collecting this data in a routine setting, you kind of create large databases of real world data. It's not as selected patients as you would get in a clinical trial, but more comprehensive. You will have like patients more likely in this with like, let's say, comorbidities, or you will assess the quality of life, the symptom burden beyond disease progression, which is frequently not done in a clinical trial context. So yeah, so these are like examples of what you might want to use this kind of data for, why you might want to collect it in daily practice. Now talking of PRO monitoring of like the routine assessment, this is just like a very quick example to give an idea of where this leads to. This is an example from Italy, from the GMEMA Alliance project, where they collect like PRO data in daily practice in more than 20 hospitals in a hematological setting.
GMEMA es el instituto donde él trabaja y donde hace investigación, y nos va a explicar cómo hacen la evaluación de la práctica clínica en 20 centros. El GMEMA es el Instituto Italiano de Hematología.
Okay, and so some years ago they would implement routine monitoring, and it's like a basic flow chart of how this looks like, this kind of approach, this kind of assessment procedure. So on the very left-hand side, you have like the patient, and they would complete questionnaires. And typically, like always, I would say, this is like done electronically via tablet PCs, via phone, via computer. The data goes into like a central database. The database, the software basically will send reminders to the patient in case they do not complete the questionnaires, kind of sort of like to increase the completion rate. The data is like immediately available to the treatment team at the hospital. So the patients might complete these questionnaires while being at the hospital for, let's say, an outpatient visit, but the patient might also complete the questionnaires while being at home during the visits. So there's a kind of a home monitoring, as we would call that. While the patient is not treated at the hospital, the treatment team will still get information about the health status. In case of concerning scores, like clinically relevant problems and impairments, email alerts are being sent to health professionals, to the treatment team basically, and they can choose how to react to the patient, for example, like reschedule a visit at the hospital, contact the patient via phone, etc. This is like a very typical, but also like, let's say, very basic setup of what PRO monitoring might look like. It's done electronically using software basically, and not always, but often it's done like not only at the hospital, but also when the patient is at home, to have like a more complete picture and be able to react to impairments that occur during the visits basically. So how often is this being done by people, basically? That's very difficult to say. Honestly, I have like this study like from some years ago that was done like worldwide, but it was a convenience sample. So like basically like people who would react to this, people who are part of the network, etc. So it's not completely clear if these numbers really translate to different settings, very obviously. But to give like a rough idea, in this survey, like across many countries, the US, India, Australia, Netherlands, and Canada, and many more, like 25% of those people completing the surveys would be considered high-frequency users. And these authors define high-frequency users as people using the questionnaires, the PRO measures, in more than 80% of their patients. And what did they use it for? They would use it to facilitate communication with the patient. So they would include the questionnaire data and the results from this in the discussion with the patient, better detect symptoms, let's say, to better adapt the treatment needs. They would monitor a treatment response, as I said earlier, and they would use these kind of data to support decision-making in the context of indication for treatment, for example, or in the context of diagnostic processes. This is like a very rough overview, but 1/4 in this survey would say they would use such data in their hospital, in their daily practice. But of course, this comes with a number of challenges and barriers. And there's like another survey, like from Stanka, a colleague from Innsbruck, and she would like survey like 223 health professionals to identify what are like the most common problems if you try or if you're doing to collect PRO data in daily practice. And she found that like nearly all of the health professionals doing this would say like it's difficult to interpret the PRO data, like the score points that I showed earlier. They're not so sure about the clinical benefits of doing this, why they should do this basically, was like really the advantage for the patient in the end. And also like how to do it, like how to implement this routine data collection into the hospital setting, into the setting when the patient is at home. And for this study was like a starting point, let's say, of a bigger EORTC project. So the European Organization for Research and Treatment of Cancer, the EORTC, is currently developing learning materials like online videos, kind of manuals, etc., like to tackle these topics and many more and facilitate the implementation and the use of such data. That's ongoing, and we expect the learning materials to be available online next year in 2025. So, but like for my presentation today, I want to focus like on these 3 main topics that occurred most frequently and were basically considered to be a challenge, a problem, let's say, for like most of the participants in this large survey. And I'm going to start with the implementation of PROs in oncological practice, and I want to build on an example that we have at the department back home in Innsbruck. And back home, we have like implementation of routine PRO monitoring in different departments. I picked the hematologic outpatient unit because basically like my colleagues would publish most on this in research articles. So there's like most information, like more details, let's say, available online to follow up on this if you're interested. But it's like very often, let's say, similar across departments what we're doing. So the population that is like participating in this is like our patients with either multiple myeloma or chronic myeloid leukemia, and they're like treated at the Department of Internal Medicine number 5. They have numbers at our university. And the main idea when this was introduced in 2016 was to improve clinical care, to improve like the treatment of the patients through routine collection of such data, but also to complement the already existing Austrian myeloma registry. So for like myeloma patients, there was a registry already in place that would collect survival data, data on treatment characteristics, etc. And the intention was also to complement this registry with PRO data, with the patient perspective on these treatments. But like a clinical use, or let's say a research-focused use for this. And what would happen is like patients within this program, they would be assessed once weekly with a short symptom list. This was like selected to be like the key symptoms for their respective patient groups, and also the symptoms that were like considered to like change most frequently over time to be not so stable. It was like one of the rationales behind this. And this weekly assessment with the short symptom list are complemented with a longer assessment with the EORTC QC 30 questionnaire that also covers these broader aspects of functional health and quality of life. Where is it done? So it's like done as well when the patient is at home and when the patient comes to the outpatient unit. It's not being done during inpatient stay because the general thought was that like when patients are like inpatients at the hospital board, there's not so much need for screening and monitoring because the contact between the patient The health professionals, the nursing staff, etc., is more close. There's like more information transferred, more things discussed anyway. So it's like focusing on the outpatient unit, on the aftercare visits, for example, but also on the period when the patient is not at the hospital but at home. And the software using has like different front ends. I'm going to show that in a minute. But it not only provides the possibility to complete questionnaires, basically, but also it provides, for example, self-help interventions like instructions for patients, manuals, where like patient can like deal with their symptoms based on these instructions, like self-help interventions, for like, let's say, lower levels of impairment, lower symptom levels. And when the patient comes to the hospital, the data is mostly discussed with the treating clinician, but I'll get back to that. And what is also in place, maybe a key feature, is like this dedicated person from the nursing staff, an onco-nurse, as we call it, that kind of monitors the data that is being collected and reacts to it by calling the patient, for example. What does it look like? So the software we are using is called CHAS. It's called Computer-Based Health Evaluation System. And there are like different features, obviously, like this is like on the slide, the clinician front end, like the view that the health professional gets. And it shows like from a specific patient, the data over time. So like you see like the bars show different symptoms, for example, fatigue, pain, nausea, vomiting. And for each symptom, you have like 5 assessment time points, so like with the date given below. And there's a color coding. And the color coding indicates if a certain score level, like a certain score, let's say 70 points, 50 points, 40 points, is something that is clinically relevant or not so much. But also as well in this data to facilitate interpretation is on the x-axis below the chart, you see like the treatment phase the patient is in, the treatment the patient is getting, with like the patient is currently off treatment. This is meant to facilitate interpretation of the scores we collect. So there's quite some information packed into these graphical displays of the data collected to facilitate for the health professional to make sense from these scores, from these data being collected. That's the clinician front end. Then we have the patient front end. As I said, like the patient can log on while not being at the hospital. The questionnaires on the left-hand side can be completed on the mobile, on a tablet PC, on a computer, whatever device you want to use. And the patient not only can complete the questionnaire, but the patient also get access to her own results. There's also kind of an important feature we feel to have like to give the patient control of the data that's being collected. So here's like a cross-sectional view. So the patient gets like the immediate results of what he or she has just answered in the questionnaires. There's like also longitudinal perspective over time to follow up on this. And on the very right-hand side, you see like here, for example, it's in German, unfortunately, but like the start of the self-help interventions for fatigue, like for exhaustion, for tiredness. So we felt it's like important to provide an incentive to patients to not only provide the data via the online portal, but also be able to access their own results and get like linked related self-help guidance in case there are like clinically relevant problems. So after implementation, it's like also an important step of this, we do like continuous re-evaluation of the procedure of the program. And some of this has been published. So we would like to approach the patients, how they perceive the program, where they see that need for improvement. So it's like not going so well, maybe. And like quite some results on this published in 2023 by my colleague Jens Lehmann. But I want to show like some of the key features here, maybe. And one critical part is always like the assessment frequency, how often you do these assessments. In some way, you want to do it more frequently to not miss out on relevant problems and be able to react timely. On the other hand, you don't want to overburden the patient by completing too many questionnaires. And our approach is basically like a shorter weekly assessment, as I said, and like a longer monthly assessment. And this seemed to, in this combination, it seemed to work pretty well, as most patients felt, like 61% in this sample of only 40 patients, I have to say. But most patients felt it's like just right, the amount of information we collect, the frequency, and some felt, about a third felt it's maybe a little too frequent what we're doing here. This will, of course, also depend on how frequent patients experience symptoms. So like if patients like doing very well, doesn't experience much symptoms, of course, it's like not so much sense from the patient perspective to keep continuing these questionnaires. One of the drawbacks that we found is like also like one of the major challenges in general. We collect these data, but the data is not often used in the clinical encounter. So if the patient comes to the outpatient visit, the data is not always, let's say, half of the time, not at all, discussed between treating clinician and the patient. That's the thing that we find in our department as a key challenge, that like clinicians will not always use this data, but that's something that's like more broadly reported in the literature. And that's in a way like a key characteristic why these programs fail or succeed. It's a bit like a drug that is not taken will not work. And it's really like a key aspect to make this data being used. In this situation, it's let's say a little less bad to some degree, because like all the results collected by patient is always followed up by this oncological nurse that is dedicated to do this. And the nurse would like get back to the patient to discuss the results. So like this work has been a little bit moved away from the treating physician, and the oncological nurse will also approach the treating clinician with these data, even if the patient is not there. So much of this data is discussed anyway with the treating physician, but not in the direct contact with the patient, which is still a problem in many ways.
Resumir un poquito, lo que está explicando tiene que ver con todo el sistema de evaluación desde el punto de vista del paciente, por un lado, el que se emplea en las consultas, y lo que está contando también es que tienen un sistema que la persona desde casa evalúa su calidad de vida. Esta información le llega a la enfermera oncológica, ¿no? Como es tu caso, ¿verdad? Y hay un sistema de alertas de que en el caso de que esas evaluaciones que hay entre consulta hay alguna limitación, se puede intervenir. Es decir, como lo tienen el sistema de evaluación que emplean en la práctica clínica con estos diagramas de barras donde se ven áreas que van bien, áreas que no van bien, pero además tienen entre consulta y consulta que desde casa el paciente o la paciente va rellenando y esa información se corrige y hay un sistema de alertas en el caso de que aparezca alguna zona roja. Luego también tienen, eso se puede, información que llega al médico. Y por otro lado tienen, incluyendo sistemas también de información de autoayuda, también un poco para poder, si tienes fatiga, etcétera, poderte manejar. Pero yo creo que en ese sentido es muy visual y lo que nos han explicado es qué piensan los pacientes de este sistema, ¿no? Y entonces, sobre la frecuencia, sobre los resultados discutidos y sobre la experiencia general, y en general la valoración es positiva.
And one thing we also evaluated is a bit like, as I said, like there's this trade-off, like this advantages and disadvantages of having a more frequent assessments, having longer assessments, because if you do like shorter assessments, less items, and we have these short item lists, you run the risk that like you miss out on important things. The patient can still like report in a free text field, like they can type in other symptoms they have experienced, other problems they have experienced. But generally what we got from the patient feedback was that the questionnaires were considered to be comprehensible enough. So it seems like that the symptoms that we would select for the assessments kind of reflect what is like the most important issues to the patient. We try to assess like, let's say, the content that we give to patients with like important symptoms are missing there. And that seemed to be not too bad, let's say. So as I said, like, so the patients complete the questionnaires also at home. And if they're like clinically concerning scores like indicate a problem, there's like an alert triggered nerve system as well. And the oncological nurse would follow up on this. And we would collect like data from 1,700 clinical alerts to see how the oncological nurse would respond to these. And I have to highlight here was some documentation problem. So we don't have documentation for all the cases. But what we find is like the nurse would very often call the patient because the scores were concerning, and to discuss like referral to the hospital services, referral to the general practitioner, or like management advice. Sometimes new medication was issued. Aftercare visits were like rescheduled, like made earlier, let's say. Very rarely there were like the calls resulted in unplanned emergency room visits.
Sí, decir, no se ha traducido, pero viene a decir qué información a partir de lo que los pacientes rellenaban en su casa, la enfermera detectó y provocó que hubiera intervenciones. Por ejemplo, manejo de síntomas, etcétera, cuando los pacientes no estaban con cita, o sea, entre cita y cita, pero estando en casa con esta información, ¿qué intervenciones hubo?
Okay, but as you can see, like making these calls and reacting to all this information requires a person, basically like it requires money, time, in the end, resource. And luckily we have this at this department. We don't always have this. And I want to highlight in this context like a quite recent Dutch trial that would evaluate such programs in the Netherlands. It's a so-called SimPro lung trial. And what they would do is to see how the resource uptake, let's say, can be improved. And they had a system where they would compare two trial arms, two approaches to this program. One in which in our setting, the patient was called when they were clinically relevant in problems. In a comparator arm, where patients were not called, but at the end of their assessment, if there were problems, they were encouraged to contact the hospital themselves. And interestingly, in this specific trial at least, they would not see a difference in the benefits from this program. They would see a similar impact, for example, on health-related quality of life, which gets better through these programs. They would see a similar impact in the so-called reactive group, where the hospital would call them, compared to the passive group, or that was the name, but the patients would contact the hospital themselves. That's a little bit reassuring because it provides an option, and if you don't have the resource, the person that is available to make all these calls. There's only a single trial right now, but it might be a bit reassuring to see there's also benefit from this kind of monitoring, even if you don't have this person that is making the contact with the patient. So key aspects in our experience, what makes a mostly successful implementation, I would say mostly because the inclusion, the patient-clinician communication is not ideal. We see that, but it's mostly successful, we would argue. It's from the very beginning, a strong motivation from the clinical team. They really wanted to do this. They were very motivated, and they would basically approach us to get this. With this additional motivation, of course, to complement the registry they had in place. As I was emphasizing, we have this dedicated person that really helps a lot. You need someone at your unit who's responsible for doing this. Maybe not only for calling the patients, but who's responsible for looking at the data, who's responsible for making sure that this data is being used by the treatment team, etc., etc. If nobody feels responsible, these programs will fail. So what we think is important is to provide an incentive to provide the patient with control over the data. So it's not enough to just let the patient complete the questionnaires. It's important to provide self-help interventions, to provide the possibility to contact the hospital, but also to provide access to the own results, which is an important feature we feel to motivate the patient to complete these questionnaires. What is important, literature, and basically us in this context, it's very helpful to have in your hospital a research unit, a group of people who have experience with PRO data. They can answer your questions, they can support the implementation. If you don't have the expertise in the hospital, you might need to get it outside, but you need contact to a group that provides the expertise to implement this basically. And maybe also a special aspect, I was mentioning the software Jazz, and it's a software that was developed in an academic project in our hospital 20 years ago. It then went to an academic spin-off that we're still collaborating with closely. And this kind of close contact between the software company and our unit is obviously helping with adapting software and keeping the IT as well motivated to support these programs. So generally speaking, back to the old survey, a previous survey I showed before, what are the barriers? And the barriers are typically grouped in practitioner-related barriers to implementation of PRO monitoring, patient-related barriers, system-related barriers. And very often it's the lack of expertise, lack of access to expertise. It's uncertainties, what PRO measures to select, what symptoms to measure, what are really the relevant problems you want to capture. In some countries, there are problems with health literacy level or literacy level in general from the patient side. Patients may perceive the PRO data collection as burdensome, if it's too long, if it's too frequent. And patients might just not want to participate in this PRO monitoring, of course, if they don't see a benefit in it, which makes a lot of sense. On the system side, it might be lack of technological support that kind of impedes the implementation, lack of staff support, pretty much what I said, as a success factor previously, or the challenges with integrating the assessment and the use of the data in the clinical workflow, which can be especially tricky if you want to collect the data in the hospital setting directly.
Nuestra traducida, ¿qué barreras se encuentran a la hora de evaluar en la práctica clínica? Dice en la gráfica de la derecha, primero, gente o profesionales que conozcan las evaluaciones con escalas de calidad de vida, PROs, ¿no? Y luego dudas sobre qué áreas evaluar y luego que no sea una carga para los pacientes y luego el contar con profesionales, pero también el sistema técnico que te permite evaluar. pero mucho, sobre todo, lo más importante es el conocimiento un poquito del área, porque luego una vez se simplifica mucho.
Okay. Basically, just to sum up, like what we feel is like for successful implementation, it's a bit like, as I said earlier, it's a bit redundant, as you know, but you need like clear objectives why you want to do it. You need to have like a clear idea what is the use that you want to make from this data. Throughout the process, it's finished now. Okay. Throughout the process, you need to reassess your procedure. You need to stay in touch with the IT side, the clinicians, with the patients, understand where the problems are. It's not something you implement once and then it just works. So you need to follow up on this with continued assessments. We did those patients interviews, for example, that I showed to better understand what the problems are on their side and make adjustments as needed. You need to make sure that you measure relevant contact. So like the barrier I just mentioned, like to select a good measure, like to measure the right symptoms is a key aspect because it's basically the information you get. You need to have like a clear procedure to identify problematic scores. And it's like the second part of my talk, how to interpret the data, how to decide what's clinically relevant or not. You need like an adequate software solution. There are right now like quite a few software packages out there and it's quickly evolving, but you need to make a decision what is like ideal for your specific setting. And it's like not just the software, it's also the company you work with because you might need them to make adjustments to the software. And that's depending on a little bit on the flexibility they show in this context. Another key aspect is you need to use the data. You need to communicate the data to the patient. And another challenge that's like a whole own topic, I would say, is like how to include the data in the patient-clinician communication, what to do if like certain problems occur. And for medical doctors, it's very often very clear how to react to physical symptoms. It's not often so clear how to react to psychological problems, sexual dysfunction, and things like that. So you need like also like trainings in place to be able to react to this data adequately, let's say. So that's like leading to the topic of interpretation, what to make from this data, how to interpret the data. But before I talk about interpretation, I want to just have like 2 quick slides on how to measure these things. So like before interpretation, you need to measure the data basically. And there's like only like a quick glimpse at that. But in the end, if you want to measure like symptoms, impairments, health-related quality of life, you need to make a decision on what questionnaire to use, on what items, what questions to use. And the most important aspect is like the content of the questionnaire. I keep emphasizing that throughout the talk because it's like just a key component. You need to make sure you pick a questionnaire, a measure that really measures the symptoms and problems that are relevant to this specific patient group that you like working with. That's like a key aspect and cannot be overemphasized. But then again, like maybe more on the technical side, on the psychometric side, you need a questionnaire that is like reliable, that is like precise enough, that really measures what it kind of intends to measure. It's not always so clear. If you want to measure physical function, you need like a questionnaire that really measures physical function, not something else. Like the whole aspect of psychometrics, you need to be like you need to have a questionnaire that is able to measure change. So if the health status of the patient changes, this should be reflected, needs to be reflected in your questionnaire, like the whole area of psychometrics.
Sí que es muy importante contar con escalas que tengan un buen funcionamiento estadístico y que permitan evaluar síntomas y cambios, ¿no?, que pueda haber. Eso.
Yeah, of course, like in like high quality translations. Many questionnaires have been developed originally in English, but of course we're using them in German. You will use these in Catalan or whatever, Spanish from my side. And the translation is not always good. So like for German, I can say like we have very often have questionnaires that are available in many languages, and the German translation is not always well done. Sometimes there are even like mistakes in it, like grammar is wrong, but sometimes it's the use of words that doesn't make much sense to patients. So like the translation is like a key issue in using these questionnaires. And then again, like you need questionnaires that are like as short as possible, but as long as needed, the trade-off of length. And talking of cancer, like very specifically of cancer research, I was mentioning the EORTC and the EORTC questionnaires. So these questionnaires in the US is more like the facet system. They're not just like simple questionnaires, but they're like usually nowadays like whole measurement systems, as we would call them. And they have like a modular approach. So you would combine different questionnaires, different parts of questionnaires to make sure you measure the right content. And it's very similar for the EORTC and the facet system, and for other systems like the PROMIS is a bit different, but very similar for the ESAS, the Edmonton Symptom Assessment Scale, and the MD Anderson Symptom Inventory. So you usually have like in cancer research, like or in cancer patients, this core part that assesses key domains of health-related quality of life and cancer symptoms and problems that are relevant, let's say, across different tumor types, different diagnostic groups. That's like the core questionnaire here in the center. But then these core questionnaires are supplemented with questionnaire modules, with extensions that are like meant for a specific patient group, for example, lung cancer patients, breast cancer patients, elderly cancer patients. And these modules complement the core questionnaire with additional topics that are relevant to this specific patient group to guarantee content validity. But then again, like these questionnaire modules take quite some time to develop. And sometimes they're a little bit lagging behind new treatments, and they might not adequately capture the side effects, the toxicity of novel treatments. You want to continue from there?
Sí, la idea es que son dos sistemas de evaluación para oncología, el EORTC y el FACIT. La idea es que incluyen un cuestionario general común y luego específicos para tumores o para áreas, por ejemplo, cáncer en el anciano, y que son cuestionarios además que se revisan porque los tratamientos van avanzando. Entonces, un sistema general, un cuestionario general y luego módulos para cada tumor o para cada área o incluso ítems sueltos.
And so to be able to be up to date with, like, let's say, the toxicities, the side effects of novel treatments, we also recommend to use like the so-called item libraries. That's a collection database basically of like for the UTC 1,000 items roughly in the same professor more or less. And these are like single questions that you can add to your assessment to assess specific toxicities that are not yet included in the modules, in the questionnaires. You can just like piece by piece build additional items to it to assess very specific problems, let's say. And these item libraries provide these items that have been validated and are available in many, many languages already. That's like a modular approach to measurement. But then, like here, continuing with the example, when you have these questionnaires in place, how to interpret the data. I've shown this previously, and we had like these score points for like different domains. And as I said, it's very obvious. It's very difficult to say what this really means. I mean, if like if like multiple assessments, you can tell the score goes up, it goes down, but still it's kind of challenging to interpret. And to support this, basically, there are different things in place. And in a clinical practice setting, you might encounter situations like if a patient has like 67 points on the physical function scale, is this clinically relevant? Is this indicating a problem or not? And you might need thresholds, cutoff scores to determine whether it's the case or not. In clinical practice as well, you also want to assess probably change. And if a patient has, for example, an increase on the fatigue scale from 22 to 42 points, 44 points, still very abstract, but you still want to answer the question, is like this change over time a meaningful, relevant deterioration or not? It's like the two basic scenarios. And in the next part, I want to focus on the first one. If you have like a single score, a single time point, how to make sense from this. Just as a side note, maybe.
Sí. La idea es que una vez que tenemos las puntuaciones, ¿cómo las interpretamos? Cuando una puntuación es significativa de que pasa algo y cuando un cambio en una puntuación es significativa de que indica que ese cambio es significativo. Es decir, en una puntuación de 70, por ejemplo, esto es clínicamente relevante, un cambio de 20 puntos es clínicamente relevante o no. Y ellos lo que lo han estudiado es desde el punto de vista del paciente, cuando los pacientes consideran que una puntuación es indicativa de que hay un problema y cuando es indicativo de que ha habido un cambio. Lo que va a explicar ahora.
So when we talk about interpretation, like we often have, like in English, we have words like clinically meaningful, clinically important, clinically relevant, and we have many different terms in this. And it's often not completely clear, I would say, what they really mean. They are often used like synonymously. Sometimes there are differences in this that are very subtle and not easy to pick up, and it's like a challenge of its own. And if like then it's like again like a distinction between let's say the context where you determine the threshold, the cutoff for a scale for a specific questionnaire, and the, like let's say the more conceptual theoretical works where people provide definitions for these terms. And what people do to determine cutoffs does not always match very well the theoretical definitions of clinical relevance. It's like a distinct problem on its own. And the message I want to give like here is like it's not easy to navigate through these terms. It's not often easy to tell what they really mean. And the most meaningful approach in my perspective is like you have to have, if you use thresholds for a questionnaire, you have to have a close look on how these thresholds have been established to really understand what they mean. I'm going to give an example. If you just look at the terms, they might have a meaning that is not very well matching what is actually being done to like develop these interpretation aids, to develop these cutoffs. So like in the project I was working on some years ago and still do like a follow-up project on, we were like trying to approach this concept of clinical importance, clinical relevance, whatever you want to call that, by doing interviews with health professionals and patients, like 150 in total. And we would talk to these people to understand what their perspective is, what makes a symptom clinically important, clinically relevant. Not just like have like a conceptual, theoretical definition of it, but like empirical data on what it really means to patients and health professionals. And the idea was like to set up cutoffs in the next step that will like let us identify scores that are like should be discussed between the patient and the treating physician. And based on these interview data, we would identify three main aspects, three components of clinical relevance. And quite consistently across patients and healthcare professionals, the most important aspects, we would use three of them, that make a symptom or problem clinically important is if it creates problems with daily life, if it results in the limitations of the activities of a patient in daily life. That's one a key component. So like, for example, pain is clinically important if it starts to impact on the daily life of the patient. Another aspect was like the worries, the emotional burden that comes with the symptom or problem. And it's not just the worries by the patient, him herself, but also like the patient by his or her family or the partner. So it's like a little bit broader. The emotional burden is not often only on the patient side, but also like on the significant other side, let's say. That's something we want to pick up in our definition of clinical importance. And maybe like more obvious, the need for help or care as a third criterion. And we would use this definition to develop thresholds for this QLQC30 questionnaire for each scale to tell like what scores are clinically important. And those are basically those scores where a patient would report a certain severity level as measured in the questionnaire. But then this severity level would go hand in hand with either limitations of life, the everyday life, worries, emotional burden, or the need for help. And if any of these three aspects would occur, we would say this is clinically important to us. And by doing so, we tried to have like a very explicit definition of clinical importance underlying our thresholds.
Para crear los puntos de corte, lo que hicieron es primero preguntar a los pacientes qué criterios son importantes para ellos a la hora de definir que hay una limitación o un problema. Entonces sería hasta qué punto te limita la vida cotidiana, te preocupa y hay necesidad de ayuda. Y entonces esto lo evaluaron con pacientes y vieron que las personas que decían que tenían una limitación en estas áreas, qué puntuaciones daban en los cuestionarios. Y eso sirvieron para establecer desde el punto de vista del paciente qué punto de corte. O sea, a partir de tal puntuación hay que tener, o es importante hablarlo porque puede haber algún problema. Es decir, antes que decían que tienen alguna limitación o una preocupación, alguna necesidad, qué puntuaciones daban y utilizaron para crear los puntos de corte.
Okay. So this was basically our qualitative groundwork, and then let's say in some way the easier or more traditional step was like to develop the actual cutoffs. So we would collect data from 500 cancer patients across Europe and use these criteria next to the QLQC30 to determine the cutoff values. And that's what the results look like for the 9 symptom scales of the QLQC30. You could basically establish on this metric from 0 to 100 points a cutoff that kind of shows if a patient has a score on the fatigue scale above 39 points, this indicates that there is a high chance that this patient will experience limitations of daily life, or has an care, or has an emotional burden like worries that are relevant, let's say. That was our approach.
Sí, o sea, estos son los puntos de corte, entonces son las diferentes áreas del cuestionario. Cuando un paciente puntúa por encima de esas puntuaciones, es un aviso de que conviene comentar qué está pasando porque puede haber algún problema en ese área. Y cada área tiene una puntuación distinta.
And the important thing to me is if you use these thresholds, you need to check basically how they have been established to really understand what they actually mean. And you cannot just use a threshold from literature without checking properly how it was like established. And these might not be the only thresholds you might want to use. For example, if you have like a stepped care program, you might have like maybe not just one cutoff, maybe like 2 cutoffs. One cutoff that triggers a self-help intervention and a higher cutoff that triggers maybe a call from the hospital. So this is like not the one and only solution. It's like one way of approaching this. So as an outlook, just quickly mentioning, right now we're like extending this work, and like we are currently developing these thresholds with the same approach, with the same meaning, let's say, for the other questionnaires that are like focusing on specific diagnostic groups. So I said earlier, there's like this core questionnaire, the QQC30, but then for specific types of cancer patients, we would like supplement this with like a lung cancer module, questionnaire module, breast cancer questionnaire module, etc. We're now doing this interpretation aids, these thresholds for all of these questionnaires, these other patient groups. And that's like the way, like as I showed earlier, like how the color coding works. Basically, we use these cutoffs to inform the color coding. Whenever a patient's score exceeds the threshold, then the bar in this chart will go red, and below it's green color coding. So to quickly sum up and go to the last part of my talk is like, I want to emphasize like for most of the more commonly used PRO measures out there, you do not need to develop thresholds yourself. Very often you find them already available in the literature. If you use them, you need to understand what they mean, how they've been established. It's an important topic of its own. Sometimes you see variation of thresholds across patient populations. So for example, there's some indication that you might want to use different thresholds for patients being on treatment compared to patients being off treatment, like in the aftercare visit. There might be some variation there. It's important, like if you go to literature and it's like a questionnaire, to be aware that like there are thresholds out there that are meant to support interpretation of data from single patients, like a specific measurement. But there are also cutoffs out there that are meant to interpret group level data, for example, to interpret the mean difference between two treatment types, group level thresholds. So some attention needs to be paid to that. And if there are no thresholds available, or maybe even on top of that, you might also want to use normative data. So for example, you might use like the mean score, like an average score from general population, interpret the data, which might be meaningful in, let's say, in a survivorship setting. Or you might want to use scores from patients at your unit, maybe even with the same type of treatment, the same type of disease, to compare your patient against and understand better how your patient is doing. That's like the normative data you might want to use on top or instead.
Un poco lo que viene a decir es que si a la hora de interpretar el cuestionario hay que ver si en la literatura ya hay puntos de corte establecidos y, por otro lado, si hay puntos de corte para gente que está en tratamiento o gente que está en seguimiento. Y si no los hay, igual se puede utilizar, por ejemplo, las medias de grupos de pacientes, la reducción media de grupos de pacientes en la misma situación y poderlo utilizar como comparación.
Is it time? Okay.
¿Sí?
Okay. Continue. So the last part anyway. So it's now about like the evidence, the research, like on the benefits from doing these routine PRO assessments, quality of life assessments in daily practice. And it's just like a quick, there's quite some literature right now. I'm going to highlight some specific studies that I find personally interesting, let's say. And the first thing I want to start with, like there's a Cochrane review now out there, like since 2021, that kind of assessed the various benefits of having these routine assessments of PRO data, of the patient perspective, of quality of life in daily practice. And this review is not focused on oncology. It's like a broader review that like includes, for example, studies evaluating PRO assessments in psychiatry, in primary care, but also oncology, but it's very broad. And they would like do a reanalysis, let's say meta-analysis of 116 RCTs, randomized controlled trial, like the most conclusive studies, I would say, involving nearly 50,000 participants. And they would like basically check across these studies what is like the evidence that like something improves for the patient by completing these questionnaires. And the key results they found is like there's no evidence, obviously, like that these PRO monitorings improved patients' health-related quality of life across medical fields. These data help to improve patient-physician communication. It improves the diagnosis, the detection of problems, notations, like it improves like the documentation in medical records. And maybe a little bit trivial, but also important to note, there are no adverse events. So compared to other medical treatments, this is something that improves the patient's quality of life, but does not come so much at a cost. There's some burden with completing the questionnaire, and it's important to understand how this data is being used to understand it's meaningful. But there's no, let's say, for example, there's no distress related on the patient side to complete these questionnaires. So it's really like a chance to have like benefits, like strong benefits for your patient without like having adverse effects. So this Cochrane review is like a broader picture, like on let's say overall across medical fields, to give like a better understanding of how the use of this data has this effect, the mechanism behind this. I want to detail like 2 specific studies, 3 maybe 2, yeah.
Yo creo que es importante, es una revisión, metaanálisis de estudios que han empleado en la práctica clínica la evaluación desde el punto de vista del paciente, mejora comunicación, mejora calidad de vida y sobre todo no hay un coste en efectos secundarios de toxicidad, entonces es bastante efectiva y coste efectiva. María.
Before I go to the RCTs, actually, I want to show like this study from Barbera in 2020, which is not a randomized controlled trial, but a cohort analysis. Basically, it's like a very large study from Canada. And in this study, they would compare patients that had completed the questionnaire, in this case, the Edmonton Symptom Assessment Scale, versus those patients who had never completed the questionnaire throughout the treatment trajectory. It's like a very broad comparison, say. Let's say it's a very rough comparison at the same time, but it's like a huge amount of data. And in some departments of some hospitals in Canada, they would collect the ESAs, this questionnaire data, to improve patient care, whereas they would not do it in other patient groups, other settings, other hospitals. And they would analyze like data from 128,000 patient pairs, like always like a pair of a patient who would complete the questionnaire at least once and a patient who did not. And they would investigate if there's like a difference in patient overall survival. And what they would find is basically like those patients who would complete the questionnaire at some point of the disease at least once, like a very broad measure, let's say, had a higher 1-year survival rate compared to those who did not. And obviously it's like a cohort study, it's like a case control study in the end. And it's like very prone to confounding. So there might be various reasons how patients differ who completed the questionnaire from those who did never do that. And so they tried statistically to adjust for a number of factors that might explain this difference. But still, like this, in this multivariable analysis, they would still find this survival difference of nearly 5% in the 1-year survival rate.
Es un estudio con el Edmonton, que por cierto en Pamplona se utiliza bastante, y la tasa de supervivencia, creo que es el resultado clave de las personas que fueron monitorizadas con el Edmonton, es definitivamente mayor que la gente que no fue. Eran una muestra muy amplia en Canadá.
But then again, it's a very large sample. It's adjusted for many statistical factors, but it's not an RCT, so it's not so conclusive regarding really the causal impact of this monitoring. And so to add on this, I want to show like smaller studies that were RCTs. And to me personally, like the most impressive study in some way, I would say, is a study done by Denis already some years ago, published in JNCI, that they would use PRO data in lung cancer patients, basically to earlier detect disease progression. It was like a multi-center randomized controlled trial with 2 study arms. And they were comparing like one study arm, there was like this web monitoring in place, pretty much what I showed earlier, where patients would complete questionnaires online while they were not at the hospital, but at home, between aftercare visits, between aftercare checkups. And they would compare it against standard of care, basically. And the idea was like with the help of this PRO data, they might be able to earlier identify disease progression and start treatment for disease progression earlier compared to the standard care arm. And the results were very impressive. And basically, they would finish the study after an interim analysis because the treatment effect was so strong, they would consider it unethical to continue randomizing patients. And in their intention to treat analysis in 120 patients, they would show that like the median survival would be 19 months in the intervention group with the PRO assessments compared to 12 months in the non-intervention standard of care group. So what is interesting here is not just a very strong survival difference, but it's also they have like additional data that helps to understand how these PRO measurements have this effect.
Ahora tenemos unos minutos para preguntas. Vamos a hacer desde la sala y también al chat, que la puedes escribir y ahora las puedes comentar y traducir. La primera que te haré, the first question I will ask is important to select the areas that are relevant for the patient. Es importante seleccionar las áreas que son importantes para el paciente.
Like the selection of the content of the questionnaire.
Sí, el contenido del cuestionario. Otras áreas que, porque no pasáis todas, sino áreas seleccionadas, ¿no? You administer selected areas. Yeah. Okay.
To respond to that? Yeah. So like, it's definitely like a key aspect to involve, if I understood correctly, like to involve patients in the selection of what are like relevant symptoms and functional health aspects you want to measure. And you can do this like in your hospital setting by like talking to patients basically, like, and including them in the implementation for selecting these. Generally speaking, when you look at most of the questionnaires, like patients have been involved a lot in the development of the questionnaires. So when I was mentioning, for example, these questionnaire modules earlier meant to supplement the core questionnaire, that says, let's say, quality of life symptoms in lung cancer patients, for example. Lung cancer patients has obviously like been heavily involved in selecting the content of these questionnaires. So like for many of the standardized questionnaires out there, you can be sure that the patients will like had like a big say in selecting the symptoms and quality of life aspects they want to have in these questionnaires.
Se dice que ve clave que las preguntas que se valoren sean áreas que sean muy relevantes para los pacientes, que participen, por un lado, en qué áreas evaluan la consulta diaria y, por otro lado, que participen en el desarrollo de cuestionarios. ¿Sí? ¿Tienes alguna pregunta? ¿Sí? El profesor Burpegui.
¿La hago en inglés o en español?
En español, ¿y la traduzco? Vale, sí, intentaremos, ¿no, Aurea?
Muchas gracias por la interesante conferencia.
Thank you for the conference.
Desde la perspectiva clínica, como médico que soy, pienso que bueno, está muy bien porque detalla la información que uno quiere recoger y hace que al médico no se le olvide indagar ciertas áreas. Pero por otra parte, pienso si esto parte de un presupuesto es que la asistencia médica está muy masificada y entonces hacemos un abordaje masivo a toda la población y detectamos señales de alarma para intervenir. ¿Hasta qué punto esto que está muy sofisticado y que realmente es impresionante los datos empíricos que tenemos, no está reconociendo una deficiencia en los cuidados médicos o de enfermería? Lo puedo traducir yo mismo si quieres.
Ah, sí, sí. Sí, sí.
I'm impressed by the empirical evidence of the benefits from this approach, but I wonder whether you are recognizing that the practitioners don't pay attention to the needs of the patient. So the benefits are clear, but at the same time, are we recognizing that we are not doing our best job with each patient?
Well, I would not say you're not doing your best job, but it's like, I would argue, like, the problem is, like, especially in aftercare settings, like, the time with the patient is usually short. And there's quite some literature out there, like, showing, for example, that, like, let's say many symptoms that the patient doesn't volunteer so much will go undetected. And usually, like, patients talk about, like, maybe, like, the 3-4 main symptoms that, like, bothering most, but they would not pick up on other symptoms, for example, because they feel they're kind of normal, even though they're burdensome. They think, for example, that some problems are normal because they get chemotherapy and they would not mention it so much. And there are symptoms like psychological problems or sexual dysfunctions or incontinence problems as well that patients don't talk so much about easily. And these questionnaires like also means to like start conversation about this by having like a lower threshold for raising these issues, for example.
Sí, lo que está diciendo, claro, que hay áreas que en las consultas no se suelen evaluar porque igual el paciente entiende que es normal tener esos síntomas o porque igual aspectos como los aspectos emocionales no se comentan, no le da corte comentar y quedan síntomas y áreas importantes sin tratar. Entonces, utilizar estas herramientas viene bien para, viendo si hay alguna limitación, comentarlo en consulta.
Es un buen punto. Además, yo soy partidario de recoger la información. Yo tengo una gran pasión por la recogida de datos y la investigación. Entonces, como clínico, me viene muy bien este tipo de intervención. As a clinician, I'm very concerned with the data collection.
Mm-hmm.
So, I appreciate this effort.
Mm-hmm. Y una, ¿sí?
Aprovecho para preguntar.
No sé, sí.
Es una pregunta, bueno, primero muchísimas gracias porque la presentación ha sido muy amplia, pero muy, bueno, con muchísima evidencia sobre los beneficios, que creo que al final es que es lo que va a hacer, ¿no?, que se continúen poniendo esfuerzos en la evaluación rutinaria de los prompts. Pero realmente solo se puede hacer evaluación rutinaria de prompts si contamos con buenos softwares, ¿no?, para hacerlo. Has enseñado el que utilizáis en Innsbruck, con las opciones de respuesta en súper claro para cada síntoma, en diferentes colores. O sea, o tienes este tipo de visualizaciones, digamos, o si no, realmente sí que exige tiempo. Y eso significa programas informáticos. No sé cómo lo habéis resuelto aquí en Pamplona o en Austria o cómo está resuelto en Italia, pero en Barcelona, por ejemplo, uno de los problemas que se está dando es que están apareciendo muchos softwares y es muy difícil integrarlos. O sea, hay un problema de demasiados softwares para un único hospital, ¿no? O sea, se están desarrollando softwares específicos para determinados tumores o determinadas patologías y es muy difícil hacer la integración.
About the implementation of different software packages in different hospitals, and each unit might have a different software.
Yes.
Okay. So there are basically two approaches to this. Like one is like what we did like in Innsbruck, because we have this origin with this company. Let's say we have like an external software vendor and we implement it in our hospital, and that's, as you say, it's a challenge. So but the thing is a bit like once you start in one department, you will roll out this software in all the other departments. The hospital IT will not allow you, in my experience, to have different softwares in different departments. So like the software vendor who gets there first has a good chance to roll it out over time over the whole hospital. But it's like not only one way of doing this. Like some hospitals have a different approach, and they would not have like a specific software for PRO data collection, but they would have like an extension of their existing clinical information system. So I was working in Amsterdam at the NKI, the Netherlands Cancer Institute, for some time. And back then they were like programming an extension of the clinical information system. That was like having like all these capabilities of like data collection online for patients, because they had like this they were like a part of the clinical information system. They would also allow patient access to their medical charts in part. The advantage was like they would not need an extra software. It was like part of their software ecosystem. The downside was like it was very expensive. And the IT company responsible for the clinical information system was semi-motivated, I would say, to implement changes. So they would do some things, but they were like always hesitant for implementing new features. And at least back then, some years ago, I have to say, we could not get color coding for the results.
Lo que está diciendo es que ellos empezaron en su unidad y esto con el programa HES y esto se amplió al resto del hospital. Por otro lado, sí que importante que la evaluación esté, por ejemplo, como en Ámsterdam, ¿no?, Ámsterdam integrada en el resto de todo el sistema de historia clínica, que forme parte, y lo único lo que dice que a veces igual hay informáticos que facilitan o no tanto y algunas cositas igual no les, como por ejemplo los colores no les dejaron, pero clave que esté integrado en todo el sistema para que no haya varios compitiendo a la vez, sí. Y la última pregunta, sí, ¿no? No, última. Sí, no. Sí.
Well, just to add to the conversation about the software. Yeah, nowadays it's important to have APIs that communicate between software, and then they can, be integrated in whatever system. If not, and previous software were developed without any APIs, but nowadays it's the most common approach.
Muy bien, que es importante que los software estén integrados. Yo creo que en el hospital están con esta idea. Thank you very much, Johannes. It's been a pleasure to have you. And we are very good friends, so it's happy to see you in Pamplona.
Happy to be here.
Okay, thanks. Thank you very much.